Hi, my name is Angel and I'm having rib remodeling and then Lipo 400 and BBL. Because my friend actually got rib remodeling. I'd heard it before, way before in the past, but I was a little unsure about it. And then when my friend got it by Dr. Marshall, she looked absolutely incredible and it just kind of convinced me to actually go through with it. I have had a BBL previously and I was not happy with my results, so it took me like a year to find someone that I really trusted. And I mean, I was following Dr. Marshall on Instagram for a long time, looking at all his reviews on, Google, Yelp, Real Self, everything. And then my friend, I also found out that she has been with him a few times and also got rib remodeling. And then I know also some other people as well who have gone to him and they just look phenomenal, so I knew I was in good hands. Once I decided I wanted to go with Dr. Marshall, I kind of just wanted to do it as soon as possible. I was kind of tired of what I was, being messed up for my previous BBL, and I just wanted him to fix me as soon as possible. Just feeling good about myself in clothes, in, bikinis, going to the beach and stuff, and like finally not having to be insecure about, my previous surgery. I'm hoping for some drama. I want a tiny little waist and I want some big hips and a big butt. So I'm really excited. I know that doctor will be able to do it for me.
This is your CT scan here. This is from the back, this is your spine, okay? You do have 12 sets of ribs. You actually have a pretty narrow rib cage already, but let's make it more narrow. So I'm gonna address rib number 12. Okay. 11, 10, and 9. So what's different about kind of what I do is I also address the front ribs. Okay. I'm going for maximal waist reduction. So this lovely patient previously had a BBL in December 2024 with Lipo 360. She still has quite a bit of fat left. She went to a cosmetic surgeon for her last procedure. She had a fairly aggressive lipo, especially here along the flanks. You can see some discoloration, which is common with over-aggressive lateral lipo, but unfortunately she was also still left with quite a bit of fat, more than what we typically would leave with Lipo 400. So if you look here, you can see a lot of this discoloration, and that's just typically from over-aggressive lipo and quite a bit of scarring as well. So the goals today will be to do Lipo 400. So, she still has a lot of leftover fat in her pubic area. And so I'm gonna address the pubic area, the lower abdomen, the upper abdomen, the bra rolls here on the side, the anterior axilla. And so that's the front part of Lipo 400, in addition to a lot of the fat that's here on the love handles and the waist. We're gonna do the entire back as well, and her arms. Did you have your arms done before?
Yes, I did.
I can't really tell, but there's a huge difference when I do my arms. Most people, when they get their arms done, they typically just get this part done, which is more of like the posterior arm. When I do my lipo of the arms, I do the medial, I do the posterior, I do the lateral, and I do the deltoid. So let's just see how much fat we get out. As far as the buttocks goes, we're going for obviously more of a disrespectful size and shape. So I'm gonna add fat kind of to this upper area where it's a little deficient, and add fat to the hips as well. This left hip is really deficient compared to the right. So we're really trying to bring more balance and symmetry. We did the oboli a few weeks ago, which really helped to smooth out some of these areas, and even when we put the fat in those areas where we did oboli, it should help to increase a lot of that projection. Based upon what I see and feel, it does look like a lot of the fat may have been previously injected into the muscle. We don't do that here. I don't inject the muscle just for safety reasons. We use the ultrasound, we put it above the muscle where we know it's safe. There's not a lot of large blood vessels there, so the risk of fat embolism is essentially zero. So with my rib remodeling or rib lux procedure, I'm gonna address front ribs, typically ribs number 7, 8 in the front, sometimes number 9 if it's attached anteriorly through cartilage to the breastbone. And in the back, we're gonna address ribs number 12, 11, 10, and 9. These are through super small, tiny incisions. I mean, literally like the size of a little dot. I go in with a tiny little needle. I'm able to address the ribs that way. No large scars. The whole goal is to narrow the waist as much as possible, but safely. So we always use it ultrasound to view the lungs, and we don't break the rib completely in half. We just do what's called a monocortical fracture, or just a one-sided rib fracture. So typically ribs number 7, 8, and 9 in the front, and in the back, typically we'll address ribs number 12, 11, 10, and 9. The goal is to convert any ribs that are considered false ribs or attached to the cartilage in the front into floating ribs, so they have no attachment, and that allows them to move it. Alrighty, so it's gonna be a crazy transformation. All right, stay tuned.
Dre sculpt.
Let's do it. All right, ready for a timeout. Patient's a 21-year-old female who's 5'8", 173 with no known drug allergies. She's here for Vaser Lipo 400, lipo of her arms, retraction to her abdomen, fat transfer to her hips and buttock, and Riblux anterior and posterior rib remodel. The STDs are on and working, correct? Any anesthesia concerns?
No anesthesia concerns.
Any nursing concerns? Any tech concerns?
No.
All right, so today I'm doing revision lipo. This patient's had previous liposuction done before. And what often you can't see under the skin is scar tissue. And so when we talk about scar tissue with previous lipo, you can kind of see how I'm trying to put this cannula through, and I'm countering resistance. That's mainly because there's scar tissue or adhesions underneath the skin, which really prevent, this cannula from moving freely like it normally does in somebody who hasn't had surgery. So revision liposuction is always going to be a little bit more tedious, going to be a little bit more work because of the previous scar tissue that forms from the liposuction. These areas where I've marked an X here, these are areas where I got to be very careful to do liposuction because she's been over aggressively lipoed before, and there's already some superficial skin changes and discoloration from over aggressive lipo in the superficial plane there. So when I get to this area out here, I'm going to be very gentle and do minimal superficial liposuction to avoid any further injury to her skin. All right, so I've completed the liposuction of the front. This was revision lipo. She previously had liposuction, but she still had a decent amount of fat left. So you can see here, I was able to get out probably closer to 1,200 cc's of fat. Now, I had to stop because anytime I do revision lipo, you have a lot of scar tissue and you have more bleeding. And so once I start seeing bloody fat come out, that's kind of like my cue to stop because I don't want to exsanguinate the patient. Even though I use a lot of epinephrine and other meds that help decrease bleeding, at some point, all that scar tissue from previous lipo, you're going to see a little bit of red, and that's just a little bit of blood loss, and so that's our cue to stop. So now that I've done the lipo, I'm going to come through with a retraction. So this is a monopolar energy device that delivers energy right here at the tip, and I'm going to go in mainly in the deep layer but also the superficial layer, and I'm going to heat up that area now. It's going to help create collagen and help that skin retract over time. Like I said, there's nothing better that tightens skin than a knife and skin removal, but for patients, especially young patients like this does provide a good option. One thing I like about this device over other devices is it has an internal temperature sensing, so when it reaches a certain temperature, the color will change, and if it gets above or at that temperature, often it will just turn off and stop. So it has almost like a safety valve mechanism for the patient so that you don't overheat the skin or burn the patient. So next up, we're going to do the rib remodeling. So the Riblux procedure, that's my trademark procedure. I'm going to address the anterior ribs first, and then I'm going to do the posterior ribs. The main reason for the anterior rib approach is twofold. One is in some patients, they have a flared rib cage, and it actually comes out and makes them look broader from the front to back position. So the goal today will be to decrease this anterior projection, and so the front ribs will assist with that. In addition, since we're doing multiple ribs in the back, some of those ribs are attached to the breastbone through cartilage. By dislocating that junction between the bone and the cartilage, that turns those false ribs into floating ribs, which then will allow for greater reduction in the waist. So it's not so much about how many ribs you actually break, it's about the strategy and the technique and how you do it, as opposed to the absolute number. Because just doing a number doesn't guarantee that anything's going to move unless you truly address what's a floating rib versus a false rib and how those are attached. So what actually happens in rib remodeling? I always like to use this analogy. Well, like this is a Q-tip, and it's almost like this is your rib. It's flexible, it moves when you breathe. With rib remodeling, I'm just going in with a tiny needle and I'm making almost like a small fracture on one part of the rib. When you wear your corset, that rib is going to continue to move in, and then eventually new bone forms around that fracture site, and that should be your new shape. However, if you never wear the corset or wear it improperly, it'll go back to normal like you never had surgery. So by wearing the corset after rib remodeling, it's going to create that angulation in the waist, and that's what's going to bring your waist in a few inches. So this is what I actually used to cut the ribs. I previously used the 18 gauge needle to kind of scratch the surface of the ribs, and so now I'm going to use this piezotome, and it only has a propensity to cut bone. It actually irrigates with a saline solution that's cold, just to help prevent skin burns or burns to the actual rib. So this is the piezotome. These are custom made tips by somebody here in Los Angeles who gets me the sharpest tips that create the least amount of trauma during rib remodeling. So you heard that fracture, so that's a monocortical fracture right in the cartilage and the bone junction there, right at rib number 7. So the goal is really to help decrease some of this anterior protrusion. So I'm gonna keep moving down, do a few more ribs, and then we'll kind of look at that immediate on table before and after result. So the Riblux procedure, which combines the front and the posterior ribs, is great for people with anterior protrusion of those ribs. And so it's a very common thing. It's not necessarily an abnormality, but it is something that bothers a lot of men and women. So by addressing those front ribs, I was able to already see a huge difference just in the anterior protrusion of the chest here. So you can see how this side, which has not been done, is certainly more elevated than this side. And as the patient continues to wear the corset, that's just going to continue to get flatter and flatter. So on that side profile, it almost looks like you have like another set of breasts sometimes, where you have that really, really prominent anterior ribs. And so this procedure, Riblux, addresses that directly. So I've completed the rib fractures on the right side now, and so I'm just confirming with an ultrasound, one, that my fractures are indeed present, so I can see a monocortical fracture, so it only goes through about half of the rib. It's not all the way through. The lung is right underneath and it's still intact, and so I'm just going through and looking at all the fractures, just inspecting them to make sure everything looks as anticipated. So this little line right there, that's my rib fracture, so you can see it only goes about half the depth of the actual rib itself, so it's only a monocortical just through one half of the rib and not the full rib. I've done that, and I'm also looking at the lung here, and I'm just verifying that, number one, the lung is sliding as it should be along the pleura, and there's no evidence of any lung injury. The lung is touching the posterior surface of the ribs. That's what we want. We don't want to see any fluid or air behind that. So now that I've done that, I've done the anterior rib remodeling on both sides, and now you'll notice a significant decrease in projection or anterior flaring of the chest. All right, so we're doing the back lipos. That includes the upper back, the middle back, and the lower back, and along with doing the revision arm lipo. She already had really, really good projection, so we're going to really scoop out this lower back, add a little bit more fat to the top of the butt here where it's a little bit deficient. You may be able to tell from her before photos that she has almost a short butt. And so we want to kind of elongate that a little bit, and so we're going to add some fat here at the top and really add some fat to the bottom, where we did a lot of the ovally cellulite release to help really expand a lot of those tissues. Okay, so I did both arms, revision arm lipo, and you can see how much fat I got out. So that's just under 1,000 cc's of lipo from 2 arms that have previously been lipo. You know, I tell people not all arm lipo is equal. A lot of patients say that the arms typically hurt after lipo, and that's very common despite us using a lot of pain medication. So if your arms didn't hurt when you got lipo, I question if you even really got anything. Okay, so what you're looking at in the middle of the screen is my cannula, and that's where the fat comes out. So above me is the superficial layer of fat and below is the muscle. So you can see this metallic structure. So that little hollow center area that's moving, that's where the fat comes out. So now you can see the fat kind of coming out and that little gray area filling up the space. But I am above the muscle because the muscle is down below and the skin is above. So you can see exactly where I'm putting the fat, above the muscle. My goal today is using ultrasound to stay safe and stay above the muscle. Alright, so the last part of this case, we're going to do the posterior rib remodeling. So I'll address ribs number 12, 11, 10, and 9 from the back, and that should really help to bring in that waist. Alright, so I've used my piezotome and I've made a small little cut on the ribs, and now we'll just do a little gentle pressure to create what's called an out fracture of those ribs. So just completed that big case, revision lipo, round 2 BBL, revision arm lipo, anterior rib remodeling, and posterior rib remodeling. So did a lot of ribs in the front. There's about 5 ribs in the front and 4 ribs on the back. They're all through tiny little incisions. The little raised white dots here, that's just where the numbing medicine goes in. It's got a little bit of epinephrine in, which turns the skin white, but that helps to hold the pain medicine in longer. So overall, we accomplished our goals, got lots of fat out from her upper back, mid back, lower back, her arms, put everything that she wanted back in her buttocks, really to expand the hips out and to add a little bit of lower projection where we did that ovally cellulite release a couple of weeks ago. So overall, very tough, challenging case, but now it's done, and overall she looks great.